What are the essential and necessary ingredients in a good treatment plan? Well, first of all, the willingness of the patient or the client. Essential. Time appropriate to the needs of whatever the treatment plan is designed to do. Organization to implement it. Skilled therapists of various kinds to make sure that those elements are preserved and interconnected and integrated. In terms of treatment for addiction, family involvement all the time and always. Subsequently to treatment, which can be one of very many different kinds. There are standard treatments and there are others that are equally effective, but the most effective treatment system is inpatient treatment for 30 to 90 days, followed by 5 years of monitoring. The monitoring means being urine tested for sobriety and abstinence, attending groups, attending a 12-step program for if you're an opioid addict, NA, or an alcoholic, Alcoholics Anonymous, together with some kind of regulatory oversight of that monitoring process. We have it for doctors and pilots. That's where these monitoring ideas came from, and it's the combination of the inpatient treatment, the looking inward, and the spiritual and psychological work that goes on in treatment, with that being monitored as the person is moving from one culture into another, the culture of addiction into the culture of recovery, which are totally different. The values are different, the behaviors are different, the goals and objectives are different, the commitments are different. So that you have to have that monitored to make sure that you stay on path. And otherwise the relapse just occurs, the world flows in, the tide comes back in, and the chances are that you'll probably relapse. The great challenge facing us now is how to translate what worked for 25 years has been very successful with pilots and physicians, and I've been in that field from the very beginning since 30 years ago. How do we make that for the general public, who are not high paid, who are not high risk professionals, and where there's no regulatory body, government, that can set standards and insist that you go for a urine test, or insist that you go for a reevaluation if your behavior is beginning to look as if you're approaching relapse or have already done so. So they're the main ingredients of a full treatment system. And as Dr. DuPont was able to point out this morning, follow-up studies after 5 years of that, of 5 years, show continuing sobriety and recovery after that. So we obviously know how to do it, we just don't know how to implement it in every sphere of society. The role of the physician, the addiction physician in a treatment, well, I'd say physician first and then psychiatrist, because psychiatrists are of course physicians, is to be able to recognize an addict. I often say myself that sometimes in primary care physicians who are not addiction physicians, the most dangerous place for an addict to be is in a doctor's office. And people get shocked at that and say, how could you possibly say that? I said, well, they will not be recognized for who they are, addicts. They will not get the treatment they need because the proper diagnosis will not be made. And because addiction imitates all other psychiatric disorders and can be depression, can be anxiety, can be circulating, modulating mood disorders, it can produce even psychosis at times or whatever. Those tend to be treated rather than the underlying addiction and the shame associated with it. So the addiction physician, who often gets patients from the primary care physician, the family doctor or whatever, has to be able to recognize that and make a treatment plan to decide whether inpatient, outpatient, what kind, what form of treatment. The psychiatrist, on the other hand, the addiction psychiatrist, had to focus again on the addiction and focus particularly on the possibility of dual diagnosis. I have a sort of a formula here. If you took all of the body of addiction patients, there are 25% of them coming into a hospital, an admission service in a hospital. About 25% of them will have addiction and an underlying mental illness. The literature says 70%. I don't believe it. And my experience of 50 years in this field shows that about 30%, 25 to 30% may have an accompanying mental disorder. They will not recover unless you treat them with the proper drugs for their mental disorder and with the treatment for addiction. On the other hand, the other 80% or 75 to 80% of people who do not have an underlying mental illness, if you give them drugs, they won't recover because they will rely upon the drugs to make them better rather than going through the work of authentic suffering that we have to go through as addicts and alcoholics in order to reach recovery. So the function of the psychiatrist is again to make the proper diagnosis and then to prescribe the proper treatment. And if the person needs drugs, by all means, of course, they have to have in detox, they have to have drugs of one kind or another. But after that, they may have to have drugs for an underlying mental disorder. And if they don't have that, they should have no drugs at all. You're just on your own with your inner self, with people giving you support in a 12-step program or counselors or whatever it might be. That is absolutely critical, and my concern is that we have far overdiagnosed dual diagnosis. Everybody's got a dual diagnosis, 60-70% bipolar or major depression, and they're grieving the losses. In fact, they're not depressed, they're actually in grief and bereavement because of the loss of a lifestyle that kept them alive for a long time as they were addicts. And the skills that they used in order to survive that time, they lose all of those coming into the culture of recovery. I don't know if that answers the question, but it's what I believe is the direction we have to go and how we have to educate physicians and psychiatrists, most of whom have never spent really any time with an addict and don't know what an addict's day is really like. We have an immersion program where I work at Bet Teshuvah in Los Angeles, where we bring people in and they become immersed for a week with the patients themselves or with the residents, and the patients and the residents become the teachers of the doctors, not the other way around. I believe so. Not it can go both ways. In most treatment programs that I've worked in, they are separated by gender. In the treatment program I'm working now, Bet Teshuvah, they're separated sometimes, but not all the time. Some groups are gender specific, others are not. It's easier because certainly women have different problems than men psychologically and spiritually, and are more likely to interact intimately together than if men are present. And a whole new dynamic comes in, the sex and attraction and these kinds of things come in, which there's nothing wrong with them except in the context of recovery and trying to look inward spiritually and learn something. They can be distractions. So I would say yes, the gender specific treatment is best, but there also should be, I don't believe in monastic gender specificity where the men never see the women at any time and during their treatment. There must be time for connecting, eating together, dining together, doing activities together outside and that kind of thing. But for the treatment, yes, I think it's probably best to. And I'm not sure that there are very many good studies on that to show, but my personal experience of several treatment centers over a long period of time would be gender specific, yeah, for the treatment, yeah. I think that medications are overhyped or overused, and we're in a sort of tsunami of medications and psychopharmacology at this point, largely in my belief because doctors in general, if you look at the Columbia studies, 90% of the doctors in this country in practice are not well enough trained to be able to recognize or diagnose or manage an addict. And yet an addicted person will be the third in their practices, no matter what it is. The addicted person will be the third most likely diagnosis to be made, and it's a potentially fatal diagnosis. So it's an appalling scandal, as a matter of fact, that the doctors are not being trained in medical school sufficiently well to be able to diagnose and manage a patient. So what they do if they don't know, they'll simply write a prescription. We have the added problem that drugs are advertised on television, so patients will come in asking for drugs. They say, ask the doctor, does such and such a drug, is it that right for you? They'll go in and ask, him or her, is this right for me? And the doctor, because they don't know what else to do, will write a prescription. And a transaction takes place. The doctors have 5 or 10 minutes to see a patient. They can't take a real history. And the patient will get what they can and get a prescription with 5 refills and so on. So I think they're grossly overused. And in the area of dual diagnosis, as I mentioned before, patients who don't have a dual diagnosis don't need medications for sleep or anything else. Recovery brings about its own tranquility, its own stability, its own situation where medications are really not required. A change in lifestyle is required. A change in the way you live and the way you are and your identity and what you do, that's required. But that's hard work, and it's much easier to ask for and be given a medication for both the doctor and the patient. But that's a fatal mistake unless the diagnosis is correctly made. And that diagnosis must be made in order to justify medications. So, on the other hand, the pharmaceutical companies, the only education most physicians have, primary care physicians have, and some addiction physicians have about medications are from the pharmaceutical representatives who come to see them, and they're obviously got self-interest, and they're trading their wares and telling the doctor that this is the best new thing at the surface on the market. And as there are so many different ways to get sober, all of these things succeed for a while and then they fade and something else comes in. So I think it's a major issue for us to consider the earliest possible opportunity, because we see the patients coming in with 5 or 6 different medications from psychiatrists. We're building one medication on the other, adding a little here, adding a little there, and none are looking at the important organs of recovery, which are the heart and the soul. That's where I say to people, have you ever had a brain-to-brain conversation with anyone? No, you haven't, but you've had a heart-to-heart talk with people, and that's where recovery really comes in, and medications are not required for that kind of exchange and that kind of connection, because medications at times will block the connection, which is so vital to the recovery process, connectivity and being connected, because we addicts and alcoholics are so isolated from society and from ourselves and from our families. We live in our own little narcissistic worlds, and to be connected with other people is both a wonderful relief, but it's also a shock to which we're not accustomed. And so anything one can do to improve that level of connection, sometimes medications, most of the time not. Well, I think that any treatment program, regardless of the particular emphasis it has of dual diagnosis, single diagnosis, process addiction, substance abuse disorders, perhaps should be based on the following principles. Obviously, transparency, honesty, directness, those values, but also should try to adopt a way of thinking that says the program is about mending broken people. People coming to programs are broken, and the people that are looking after us, me, other counselors, psychiatrists, are also broken. Mending broken people, healing damaged souls, because that part of the person is damaged because of the stress and of addiction for many years, and the violence and all of the things that go with it. And finally, recovering your passion. Recovering your passion and discovering your purpose. And finally, ultimately, restoring your integrity. I think they're elements that we're looking at a program that one needs to be able to identify and see, are they being fulfilled. Of course, there are many different ways of doing that. But those values, I think, are very important to any program.